this is Sensory Alterations. This is going to be part one. We're going to discuss eye trauma. This is from chapter 49 in your medical surgical textbook. There's a list of the objectives for a module. Okay, we're going to start with refraction. Emmetropia is the perfect refraction of the eye. Amblyopia, or lazy eye, is the loss of the ability to see details. The most common cause of vision problems in children. 1 in 40 children will have this problem. And here you can see there's a blurred view and a normal view. What happens with amblyopia is the child does not see the blurred view because the brain makes it so that they only see their clear picture. So they don't really realize a lot of times they have a vision problem until they get an eye check. Strabismus is a disorder where two eyes don't line up. So it's where you have the wandering eye. Amblyopia is not a wandering eye. It's just where one eye doesn't have good vision. Strabismus is the one where you talk about the wandering eye. The treatment for either one of these is the eye patch. Which eye do you patch? You patch the good eye, the eye that's working. Gets patched so that it makes the lazy eye, whether it be the one that's not seeing clearly or the one that's wandering off to the side, act so it's having to line up and see correctly. Other refractive errors, one is astigmatism. That's where the cornea is wompy. So you have a distorted view. A lot of times people with astigmatism complain of night vision problems. Presbyopia is problems with aging. The lens loses its ability to focus, making it difficult to see objects up close. So the near point of vision increases. In other words, your arms get too short. You can't have your arms long enough to be able to see the end of the book or to be able to see vision clearly. So what vision goes first when you're talking about presbyopia? That's your near vision, right? Usually when you get older, what you have to do first is get some reading glasses. Other things that are affected with aging, you can get the arcus senilis, which is the gray ring around the eye. That doesn't affect the vision. It just sort of looks odd. Also with aging, the pupil is smaller and it is more difficult to dilate. So what do you think that would affect? That affects our ability to see in darkness, because if the pupil doesn't dilate, the dilation of the pupil is what allows us to take in light so we can clearly see in dim light conditions. If we don't have that, then we cannot see in dim light. So it's difficult to see in the night. Like if you wake up at night, have to go to the bathroom, your eyes don't dilate quickly, so it's very difficult to see. What is an ectropion? Ectropion is where you have the eyelash, the lower eyelash lid usually, that goes out, flips out. If you've ever noticed on an elderly person where you can see a little bit of pink, the conjunctiva, and where the eyelash should be, that's mean the eyelashes are turning out. What do you think that would cause? That's dry eyes. And the reason is because the tears, instead of being able to stay and coat the eye, they easily run out of the eye. If you want to see other things that are affected by aging, that's on page 1043 in your textbook. Changes in the eye and vision relating to aging. Other refractive errors, you have nearsightedness or farsightedness. Myopia is nearsightedness and the image lands in front of the retina. Hyperopia is farsightedness where the image lands behind the retina. And we know we need something to land directly on the retina for our vision to be perfect. What's the treatment for any of these refractive errors? There's a couple of different things. One is glasses. Usually the most common treatment for the refractive errors is glasses. The second thing that can happen is a lot of times what they do is LASIK. What is LASIK? It's where they do a laser and they laser the back portion of the eye to create it so that, for instance, in myopia, they laser the back of the eye create little bitty scar tissue, so when the eye heals, it heals up a little bit shorter, so that then the image is falling directly on the retina instead of in front of it. Eye trauma. A couple of things we need to remember about eye trauma. First of all, if we're having eye trauma, we always want to check the patient's vision. Now, if a person comes in with a chemical burn, we're not going to pull out our Snellen eye chart, put them 20 feet back and say, can you please tell me what 9.3 is? Okay, that would be ridiculous, right? So what would we do instead? Can you think of a simple way you can check a person's vision? The easiest thing to do is to hold up some fingers. Say, how many fingers am I holding up? You just want to get an idea of if they can still see out of that eye, and if so, can they still see fairly clearly or not. So if a person comes in with eye trauma, what you want to do first is check their visual acuity. Some different types of eye trauma. First, we're going to look at some pictures here. Okay, some pictures. Hematoma, that's a contusion or a black eye. This is the picture here. Chemical burn. That would be this picture. You can see where the cornea is just completely burnt out, basically, with a chemical reaction. Corneal abrasion. That would be here or here. It could be a laceration. This could be an abrasion. You can see where the cornea is just sort of eaten away here. Laceration, you can see where there's a slit in it. Penetrating injuries, obviously, that would be the fish hook to the eye, good day gone bad. Foreign body, that would be something like right there, like possibly a welder that's gotten something foreign in their eye. So if we're thinking about eye trauma, we said, what do we want to do first? One is assess their visual acuity. We want to see if it's something like a laceration. Does it look like their globe has been penetrated? Has it gone deep into their eye? If a person has a laceration, our concern is a possible perforation. If the cornea gets completely lacerated, then we have the possibility of that eye literally popping out, which is something we definitely want to avoid. If we have a patient come in with the laceration or the abrasion, do y'all remember what it's called? When you, what this thing is that makes it green, that's the fluorescein. That's how you assess those. If they have a foreign body or something penetrating their eye, some things we want to remember. If it's some kind of metal, we definitely don't want to do what test? That's an MRI. No MRI, because this could literally pull the eyeball out. If they have something foreign in their eye, we also want to assess, have they had a tetanus shot? If they've had a tetanus shot more than 5 years ago, we're going to want to give them a booster. Common complaints for trauma would be pain. You would worry about photophobia. Do they have problems seeing lights? We also want to ask them if they have any floaters in their field of vision. When we talk about floaters in their field of vision, that usually means internal bleeding inside the eye. So no matter what the cause of the trauma is, first, visual acuity. Second, what part of the eye was affected. And then we want to look at it specifically for the different causes. So if they have a contusion, what's going to be our nursing intervention for a contusion? What do you do for a black eye? Put some ice on it, right? Foreign body or penetrating injury. Obviously, they're going to need to see the ophthalmologist. We're going to need to consult the doctor, let them remove this in surgery. A laceration, we want to make sure that their eye doesn't pop out, so we want to teach them to reduce interocular pressure. Do y'all remember the things that reduce interocular pressure? Reducing interocular pressure, things that do that would be don't cough or sneeze, don't bear down to have a bowel movement, don't bend over at the waist, don't lift objects weighing more than 10 pounds, don't blow your nose, don't vomit, don't have sexual intercourse, or have your head in a dependent position, meaning bent over. All those are listed on page 1059 in your textbook. Treatment of a chemical burn, that would be you need to rinse the eye out. It's very important to rinse that eye out as quickly as possible. So you're going to need to review how you do ocular irrigation. That's on page 1072 in your textbook. There is a chart 49.8. So please review that. Make sure you know how to do ocular irrigation. That is something you will need to do in the emergency room sometimes. And basically you use IV fluids, sterile saline in an IV fluid bag, hook it up to a tubing, and then there's a ocular piece that you put on the end instead of something like a Heplock, and the ocular piece fits inside the eye. You turn it on, and then that whole bag of fluid will drip in and rinse the eye out. If a person has something that gets into their eye at home, what do we want to advise them to do first before they come anywhere? We want to advise them to rinse it out at home for 15 to 20 minutes. It's very important that they rinse their eye out immediately. And in that case, obviously they don't have sterile saline, so tap water. Anything to get the chemical out of the eye is better than nothing. So I always tell patients if they get something in their eye, rinse it out at home first, then come to the emergency room. So this is trauma, eye trauma. Eye infection or eye inflammation. When we talked about trauma, we said the first thing we want to do is always check acuity. Infection or inflammation, you always want to check acuity for that also, but it's not as important as doing it with the eye trauma. Infection or inflammation, a lot of times we want to focus on, the focus is usually avoiding spreading the infection. We don't want to spread the infection. So let's look at some pictures here. Okay, conjunctivitis. Conjunctivitis, that is pink eye. Okay, so what's the main symptom of pink eye? It's usually pain, burning, tears, and then you have large amounts of exudate or drainage. So this is pink eye. See all that matter coming out of the eye? That would be an example of bacterial conjunctivitis. This is very easily spread from one eye to another, from one person to another. So hand washing is very important patient teaching. Another common infection is blepharitis, which is an infection of the eyelid edges, or seborrhea. Seborrhea is greasy scales. This is blepharitis. Very similar to cradle cap, or seborrhea capitatis, which is cradle cap in infants. The treatment for that is diluted baby shampoo, and that's the same treatment for this also, diluted baby shampoo. And then the other thing, after you wash it with diluted baby shampoo, warm, moist compress, which for most of these infections, that's a good treatment. Eye infections is usually warm, moist compress. Don't spread it. Keratitis. Keratitis is a corneal ulcer infection or trauma, which the example of that on this picture is this. And you can see where the cornea's got this discoloration where it's worn away. The most common cause of keratitis is contact lens wear. It can also be caused by surgery or by viruses like herpes. Shingles can cause keratitis. Patients with keratitis usually complain of pain, foreign body sensation. You feel like something's in your eye, although nothing is there. They usually also get blurred vision. Another infection is a chalazion. Chalazion is trapped sebaceous gland, and that would be this picture. See the sebaceous gland on the edge? That's where they're trapped. That's a chalazion. Treatment for that is warm, moist compress and eye drops. This is a hordeolum, the other name for a hordeolum right here. That's a sty. Symptoms of a sty is pain and redness along the eyelashes. Treatment for these, the conjunctivitis, the chalazion, the hordeolum or the sty, all those are going to be warm, moist compress and antibiotic eye drops or either antibiotic eye ointment. key things with antibiotic eye drops or ointment is how to administer them. Please review charts 48.4 and chart 49.1. Those are in your textbooks, chart 48.4 and chart 49.1. That talks about installation of eye drops. That's on page 1050. And also page 1053 is the ophthalmic ointment. One thing you need to remember about eye drops is a lot of times the eye drops are antibiotic eye drops, and sometimes they're antibiotic eye drops mixed with steroids. That's fine if you get them from the doctor gives them to you. You never want to share steroid eye drops with another person, because if you have a person with something like, let's say, keratitis, and instead of it being caused by bacteria, it's caused by herpes or shingles, well then what's going to happen is the eye's going to feel better, right? Because we're giving them some steroids. That steroid's going to decrease that inflammatory response, so they'll feel better for at least a few days. But what's happening to that underlying viral infection? It's actually getting much worse. And so in the long run, their infection is going to be much worse, and it's going to be much more difficult to treat. So you never want to share antibiotic, or rather steroid eye drops, especially with anyone else. Very important. The treatment for keratitis would be a corneal transplant. Corneal transplant. If you look in your book on page 1058, there's a picture of an eye with a corneal transplant. You can see how they stitch that in. Where do the corneal transplant, where do those tissues come from? Those come from cadavers or dead people. If a person is dying, you do want to ask their family if they would be interested in donating their corneas. If so, you want to make sure you leave their head of the bed up, at least 15 to 20 degrees. You want to put antibiotic ointment in their eyes, and also ice on their eyes to keep the corneas good, so that they would be good for transplant. If a person gets a corneal transplant, you want to also remind them to avoid the things that that increase interocular pressure, which are the same things we already talked about, found on page 1059 in the textbook. Okay, so if a patient has a corneal transplant, what's our priority intervention? We do want to assess for signs of infection, but that's not the priority. If the patient strains to have a bowel movement, especially soon after a corneal transplant, it can literally pop that transplant off. So the priority thing is to avoid straining after have a bowel movement, which would be the B answer. Okay, that's going to be the end of part 1. That covered eye infection and eye trauma. Just to review, eye trauma, assess for vision, visual acuity. You also want to avoid MRIs or anything like that with any kind of foreign body. Spots or floaters in the field of vision can be internal bleeding. Review of infection is hand washing is very important. You want to do warm, moist compresses and antibiotic ointment or drops for the conjunctivitis, the chalazion, or the hordeolum. Keratitis is where you have the corneal ulcer. The treatment for that would be treat whatever the disease is that causing the ulceration. If it's too late for that, then the patient may have to receive a corneal transplant. If you have any questions, please let me know. Thank you.